Good afternoon, I'm Dr. Giulio Falasconi from Tecno Medical Center, Barcelona. I'm speaking on behalf of Dr. Diego Penela and Dr. Giulio Zucchelli. The title of this review is Transcatheter Options for Atrial Fibrillation Treatment, an overview of the ablative techniques currently available and future perspectives. I will talk about a representative case of zero fluoroscopy approach and atrial fibrillation radiofrequency ablation. This slide is only to introduce the topic. Atrial fibrillation is the most common arrhythmia in the adult population. It is an arrhythmia that becomes chronic, increases mortality, morbidity, and reduces the quality of life of cardiac patients. In the latest European guidelines, indication for transcatheter ablation have increased the class of recommendation. Simplifying, the class of evidence is always 1A for patient with atrial fibrillation and antiarrhythmic drug failure, 1A for patient with tachymyopathy, and class 2 for ablation as first-line therapy in drug-naive patients. This is thanks to the fact that the first study on AF ablation in the recent year has been followed by a growing number of randomized trials in support of the greater efficacy of catheter ablation compared to antiarrhythmic drugs. These are the randomized trials. Since 1998, in the field of interventional cardiology, the acronym ALARA has been postulated in the American College of Cardiology. Radiation must be kept as low as reasonably achievable. This is due to the awareness of stochastic and deterministic effects in humans and the vital importance of minimizing radiological exposure for both patients and exposed healthcare workers. There are already numerous studies in literature on the performance of zero fluoroscopy ablation for arrhythmias affecting the right chambers. Concerns regarding the transeptal arches have limited the fluoroless approach for left atrium ablation. All atrial fibrillation procedures in our center are performed with a zero fluoroscopy approach, using a non-fluoroscopic 3D navigation system with a single catheter technique, with a single right venous femoral arches and a single transeptal puncture, and using general anesthesia with a ventilation protocol called high-frequency, low-tidal volume ventilation, which allows for greater stability of the catheter. All transeptal punctures are guided by transesophageal echocardiography, as we can see. This slide represents the personalized ablation protocol performed in our center. The idea of the protocol is due to the fact that we are aware that non-transmural ablation is considered a major determinant of post-ablation recurrence. Elada et al. Showed that pulmonary veins reconnection could be due to insufficient lesion depths. Left atrial wall thickness ranged from 0.5 to 2.2 mm in the posterior wall and from 0.8 and 4.4 mm in the anterior wall. Fixed ablation in that target and dichotomized anterior-posterior ablation approach could be an oversimplification and may not fully reflect this variability, leading to a non-transmural lesion in the thicker regions of the left atrium and, on the other hand, excessive radiofrequency application in the thinnest one. So we can see this pre-procedural image flow chart. Multi-detector computer tomography study was performed prior to the procedure in all patients. The left atrial wall thickness maps were semi-automatically computed from the multi-detector computer tomography as the local distance between the left atrium endocardium and the epicardium, and then integrated into the navigation system. The left atrial wall thickness was categorized into 1 mm layers, and ablation index was titrated according to the left atrial wall thickness. A color-coded map was deployed as follows: red less than 1 mm, yellow 1 to 2 mm, green 2 to 3 mm, blue 3 to 4 mm, purple more than 4 mm. Ablation index is adjusted according to wall thickness. The greater the thickness, the greater is the ablation index delivery. The information of the multi-detector computer tomography post-processing also allows us to visualize the points where the esophagus is closest to the atrium, in order to increase the safety of the procedure and to reduce the application power and also the energy delivered in the part of the left atrium and the posterior wall nearest to the esophagus. The ablation lines were personalized to avoid the thickest regions of pulmonary vein antrum and the zone of the antrum nearest to the esophagus position, according to the TAC information. The procedure starts with a single right femoral vascular venous access guided by ultrasound with a linear probe, as we can see in this picture. The guide is positioned in the superior vena cava, and the correct positioning is visible on the transesophageal echocardiography in a bicaval view, as we can see in the image. Now we can see the pullback maneuver. The pullback maneuver is a movement performed in bicaval view in order to see a plan with superior inferiority information. We can see in the video the pullback maneuver, and the sheet with the needle is pulled back in the fossa ovalis. As we can see in this X-plane view, tenting is then performed and the needle is positioned in the fossa ovalis. The position of the needle is checked in relation to the anteroposteriority in the short axis view of transesophageal echocardiography. Here we can see an X-plane view, and also we can see the distance from the aorta. The needle is then exposed and the punction performed. After the puncture, when we supposed to be in left atrium, the three things that we do to make sure that we are in the left atrium is to look for saline fluid at the transesophageal echocardiography in the left atrium, to see the pressure line and to check that the pressure line is as LA pressure and not right or worse aortic pressure, and to take a blood sample and to see that the blood sample is an arterial sample. Firstly, the dilator is advanced and then the sheath, and we can see in the video, and we can see a double tenting release. When the sheath reaches the correct position, we remove the needle and we observe a double track image. The ablation catheter is then advanced into the left atrium. To do this, we use the ultrasound and the navigation system guide. In the transesophageal echocardiography, we can see an hyperechoic image filling the double track image, while in the navigation system, we see that as the catheter reaches the cavity, the black lines at the base of the catheter turning gray. Subsequently, the sheath is withdrawn towards the right atrium to minimize the risk of air embolism, and the catheter is positioned posteriorly and placed into the right upper pulmonary vein to begin mapping and to avoid the left appendage and the non-protected area at the level of anterior wall of the atrium. We can see here the ablation catheter in the left atrium. The fast anatomical mapping is guided by the signals and by the navigation system, and utilizing the information of the multi-detector computer tomography. Moreover, in the transesophageal echocardiography, we can see when we are in the mitral annulus. Vein ablation is performed with a point-by-point technique, as we can see. The ablation phase begins at the anterior superior part of the right veins. This avoids the vagal response that would occur when starting to ablate from the left veins. The ablation is guided by the Visitax system and with a distance of ablation points less than 6 mm to avoid gaps. Before initiating the posterior wall, the transesophageal echocardiography is removed and an esophageal temperature probe is placed. At the same time, the position of esophagus is always verified through the esophageal isodistance map from the computer tomography information. In these slides, we can see the point-by-point ablation, the isodistance map information with respect to the esophagus position, and the completed pulmonary vein isolation. Then the success of the ablation procedure is comproved with a single catheter technique and comproving the bidirectional block. Here we can see graphically reported the violin plots of the differences within between the zero fluoroscopy approach group compared to the historical cohort in which the zero fluoroscopy approach was not used. We see a significant reduction in the exposure and the fluoroscopy time and the fluoroscopy dose in the zero fluoroscopy approach cohort. Thank you very much for the attention and for the possibility to expose this zero fluoroscopic atrial fibrillation ablation case.